us know. I think we all know. Um, and Ben Collins came to us as a clinical informatics fellow from Philadelphia, and after a spectacular fellowship here, he is now at Vanderbilt doing an ethics fellowship, creating a completely new pathway for himself. And he is here, back by popular demand, to speak with us. So with that, Ben, take it away.
Yeah, thanks for the introduction. I'll share my screen here. All right, do you see the slides?
Yes.
Yep.
Okay.
Yes, it looks great.
Yeah, so I don't know if everyone here knows me, but for anyone who doesn't know me, as Vishnu mentioned, I completed a clinical informatics fellowship at OHSU this past summer before moving to Vanderbilt University Medical Center, the Department of Biomedical Informatics, and the Center for Biomedical Ethics and Society, studying ethics, legal, and social issues of artificial intelligence in healthcare. So today I'll be talking about the mistrust of minority patients in healthcare and how the use of emerging technology and AI influence this for better or for worse. I have no conflicts of interest or financial disclosures for this talk. I would like to take a moment to thank Paul Gorman for inviting me to give this talk. And I also want to make note that some of this work represented in this talk began while I was at OHSU. And while I don't have time to go through a list of names, a great many people from both OHSU and from Vanderbilt and elsewhere were involved at various stages, giving advice, feedback, and helping to take the work forward. I'll begin by providing some background on the use of technology within the domain of healthcare, including some context for why considering the trust of minority patients is important. Then I will discuss 3 problems related to trust and the use of technology in healthcare, including a lack of awareness of bias, low inclusion of minority populations, and insufficient education and training for healthcare professionals. Then I will briefly touch on some work currently being done to address these issues and provide some suggestions for taking next steps before wrapping up a summary of key points. And after that, I'm hoping that there will be still plenty of time left over for questions and discussion. So progress in technology has long been part of healthcare, but we are at a point of a paradigm shift involving digital technology in healthcare, which fundamentally changes even how we think about health and illness and will reshape the relationship between healthcare and patients. And technology does not exist in isolation. There are social pressures that lead to progress in technology, and there are also effects of technology on society. As technology influences and is influenced by society, it cannot be morally neutral, but it is often still taken to be of neutral moral standing. One of the prototypical examples of showing how a technological artifact may not appear neutral is actually in the development and use of bridges. In the article, Do Artifacts Have Politics by Langdon Winner in 1980, he wrote on the design of bridges with low overpasses in Long Island, New York, being constructed intentionally to physically divide the location by race and class. From another perspective, philosopher of technology Don Idy developed the idea of post-phenomenology, in which relations between humans and technological artifacts are examined, focused particularly on technology as mediators of human experiences and practices. This socio-technical perspective is important to understanding not just technology within the larger social context, but also within the sphere of healthcare. The coexistence of technology alongside society has long been apparent within healthcare. For example, the stethoscope, which has been regarded as the primary tool of the physician, developed by René Laennec, was made in part because of his consideration for social etiquette, as he was reportedly embarrassed to place his ear on the chest of female patients to listen to their heart. Similarly, the COVID-19 pandemic led to leaps in the area of telehealth. While one may believe in the technological imperative or the idea that progress is inevitable, the adoption of the electronic health record in the United States did not take hold widely until it received the policy and financial support from the HITECH Act. And the relationship between technology and society is not a one-way effect. There's also the effect of technology on society reflected in healthcare as well. For example, technology has led to the use of medical testing, which has revealed asymptomatic states as being aligned with disease or pre-disease states, which has reshaped what is perceived as being healthy or ill. This sort of medicalization will increase along with progress in technology, such as with the use of genetic testing and predictive modeling. But with these emerging technologies, such as predictive modeling and other forms of artificial intelligence applications in healthcare, it is not yet clear what the social effect will be. That question remains open, and it is very much dependent on how those technologies are developed and used. Quoting science fiction writer Arthur C. Clarke, who wrote, "Any sufficiently advanced technology is indistinguishable from magic," you may recognize the background image here as being from the Disney cartoon Sorcerer's Apprentice, where Mickey Mouse is the apprentice of the sorcerer Yen Sid. And when going away, Yen Sid leaves Mickey in charge, and he is tasked with moving pails of water. Wanting to find a shortcut, Mickey uses magic essentially to program brooms to move the water in his place before falling asleep. And suddenly Mickey wakes up, now drowning in water. The brooms have gone too far with the water, but they were just following the instructions of Mickey. They didn't do anything against their instructions, and yet now Mickey has a big problem on his hands. In his book, The Alignment Problem, Brian Christian points out how this is comparative to the way things can go wrong with artificial intelligence and digital algorithms. Computers only do what we tell them to do. Artificial intelligence is a branch of computer science using digital algorithms to make complex decisions, with algorithms being a set of step-by-step instructions for computers to perform tasks. There are intended benefits in healthcare, one of the largest being efficiency, which is also the same type of benefit that Mickey was aiming to accomplish. But there are also a lot of potential unintended consequences and harms. These harms are generally not computer error, but human error. And unfortunately, we have a long history of poor judgment and bias as humans. In the example of the Sorcerer's Apprentice, presumably Mickey has learned his lesson and no one is hurt. However, that is not how things tend to happen in real life, especially in healthcare. Shifting gears before moving on, let's take a moment to talk about trust. Trust can be defined as the general expectation that the words, a promise, or statement of another individual or group can be relied on with an underlying belief that an entity will help reach a desired outcome under difficult or uncertain circumstances. Trust is typically thought of occurring between persons and often considered in the context of healthcare, but this can be extended to include trust between humans and groups or organizations, as well as between humans and systems or machines. There are many factors which influence trust, but this presentation focuses most on the influence of minority status. The distinction of majority and minority status is often perceived as a distinction of power. In many cases, the minority population has less power than the majority population, making it incumbent upon the majority population to not use that power unfairly against the minority population. But historically, this has not worked out well for many minority populations, in part because of historical injustices and ongoing problems, characteristics which may identify a population as being of a minority group are often associated with a decreased level of trust. In this framing, it is important to acknowledge that mistrust is not being aligned as a negative. It is really a normal response to not develop trust or to lose trust under such conditions. There are numerous minority groups which have had their general levels of trust decreased. In this presentation, I'll focus on sex, gender, race, ethnicity, and LGBTQI plus minority groups. These are not simply factors of trust, as they have strong effects on how well trust is built and maintained. But why is trust important to consider in healthcare? In healthcare, patients who exhibit lower levels of trust tend to utilize healthcare poorly, including both over and underutilization of care, and to have worse outcomes. In addition, the quality of patient experiences are shaped by their trust. Minority patients tend to have lower trust in healthcare, contributing to health disparities. This trust has historically been one between humans, the patient and the clinician, and between a human, the patient, and healthcare organizations or the larger healthcare system. That dynamic is changing. The increasing use of technology and digital tools by patients directly and by clinicians or the healthcare system in work related to patient care means that this concept of healthcare trust is extending to trust in technology. And like with healthcare, minority populations tend to have lower trust in technology. Any discussion of artificial intelligence and trust is incomplete without some discussion of the concepts of transparency and explainability. In short, transparency is about being able to see what is being done and why, while explainability is about how it is being done. These concepts are often used to suggest that AI must be transparent and explainable to be trustworthy. Consider the comparison to how mechanical device functions, such as a car. Most people cannot explain how a car works, but still trust it to do what it is supposed to do. Furthermore, knowing how cars are made, how they operate, and how they are used, as well as knowing about traffic laws and transportation policy, does not really help anyone understand how cars affect life. Similarly, disclosing the code of artificial intelligence does not necessarily reveal how AI works, especially in the context of society, and will do little to understand the impact of AI on healthcare and health decisions, both from the perspective of clinician users and patients. In other words, AI explainability, at least how it has often been conceptualized, is not in itself the source of mistrust. Then what is the source of mistrust in technology for healthcare, especially among minority populations? The answer to that is likely the perceived risk of harm. And for minority populations, this is largely attributed to bias. This leads us into the first problem related to mistrust of minority populations in emerging technology and AI for healthcare, the lack of awareness of bias in those technologies. The awareness of bias in technology gains even more importance because computers and digital information are very easy to disseminate, creating the potential for biases to have widespread impact. And as Friedman and Nissenbaum stated, if the system becomes a standard in the field, the bias becomes pervasive. A bias is any systematic deviation from the truth and the processes that lead to such a deviation. There are two main forms of bias, both of which are important in the context of healthcare. Statistical bias, which refers to distortions of statistical data or analysis, and social bias, which refers to an innate or learned tendency in favor or against an individual group or belief. Healthcare has a long list of historical injustices related to biases, which I will not get into much detail on. Many of them are widely known, and some of them are less widely known, but what is not well acknowledged is how bias continues to be a part of the story of healthcare. In 2016, the study showed there remains a disparity in the assessment of pain based on patient race, where Black patients were systematically believed by medical students and residents to have less pain than white patients. More recently, and actually earlier this week, an article showed up in Stat News detailing the racist history of a nephrologist editor for UpToDate, which many healthcare professionals look to for guidance in providing evidence-based clinical care. And in addition, women have continued to be considered as non-standard in healthcare and research, still underrepresented in clinical trials, and from that, often suffering from worse outcomes of drugs that are marketed after those trials, in particular related to higher levels of adverse drug reactions. There's a similar story of bias when looking at the use of technology. Cameras provide a clear example of bias in the form of technology. The focus on individuals with lighter skin in the initial development and use of cameras resulted in poor quality and distortions in the images of persons with darker skin. This became ingrained in systems, and while there have been improvements in cameras and their use, it remains an issue. Another common example is the Compass predictive modeling system, which was used to predict the likelihood of recidivism among those who had been arrested. This predictive model was found to exhibit biases against Black persons. And these are just two of the examples, but the list is far longer. And now we get around to bias in the use of technology for healthcare, where again, there are dozens of examples. A common device for monitoring heart rhythm, the Holter monitor, released in 1960, though at the time it was known that women tend to have higher resting heart rates, but there was no evidence to suggest that women were adequately represented in the validation of Holter monitors. And subsequently, other differences were found that were not known at the time, such as in the QT duration measured in ECGs. Yet even by 2002 through 2007, women were only 1/3 of the participants in clinical trials to evaluate cardiovascular devices. And even now, most consumer wearable studies have not reported or examined for sex, gender, and skin tone-based differences. In a study that specifically reviewed wearable devices for these types of differences, it was found that there are numerous clinically significant differences. And this bias goes beyond physical devices. For example, documentation in the EHR has been shown to pull in racial bias. And currently working with Sam Lindner and Ben Orwall on a study looking at the use of behavioral flags for patient violence, which has been showing that there are other biases and social constructs pulled in by the electronic health record. So how do these biases get into these technologies intended for patients and result in harm? As suggested with the example of the Holter monitor, it is in part due to a lack of awareness. Developers and end users and others involved in the use of AI systems often do not foresee the discriminatory effects of technology, and they may not be sufficiently aware of the problem of bias or their own biases. This isn't just something that was an issue in 1960 and is now gone. Like with the examples of bias in pain assessment and the editor at UpToDate, these biases are also still very much present in the development and use of health technology today. But as we increasingly rely on technology, there's a risk those biases will become less visible. Relying too much on technology and trusting technology too much would then result in an automation bias. As suggested when discussing trust with the risk of bias in mind, mistrust of minority populations in the use of technology for healthcare may well be warranted. But again, things are more complex than they seem. This history of injustice and bias we have discussed has led to poor healthcare access for many people, and recognizing the lack of access to healthcare and the potential for technology and AI to improve access, there are areas in the world where people of minority status may have higher levels of trust in technology for healthcare than the majority population. Indeed, this was shown to be the case in a study by PricewaterhouseCoopers, where persons living in lower income countries were much more open to the use of AI and robotics for their care than those living in higher income countries. But we really still don't know enough about how well these systems would work in those circumstances and what choices that different populations may make about the use of AI for their care. For AI systems in the United States, regulatory agencies don't require large sample sizes or breakdowns of study populations by race or gender. Furthermore, as suggested by the term minority, there's always proportionately less data available about minorities. This brings us to the second problem, the insufficient inclusion of minority populations. To start, it isn't always even clear how we are using different terminology. Even in peer-reviewed research literature, the terms may be falsely interchanged, complicating and confusing the interpretation of the research. And there are several examples of this. Although sex and gender have acquired political undertones, there is an important distinction between one's biological sex and social gender that is essential in healthcare. And yet many studies continue to use the words interchangeably. A similar issue arises with the use of the terms race and ethnicity. It can be difficult to read a study and determine exactly what the study means when these words are used. In the case of LGBTQI+ populations, Claire Cronk at Yale has done excellent work on building an ontology and recognizing that this ontology is in flux. A word used today may not have the same meaning as it did 50 or even 10 years ago. So how do we actually deal with all of this? And I can assure you that the solution does not include ignoring the problem. In studies on the use of machine learning in clinical decision support systems, nearly a quarter did not report sex or gender. And note that even here, the interpretation of the statement is unclear. There are similar issues with other minority populations. Instead, these studies or those interpreting the studies will assume that the findings generalize to a wider population without actually looking at those populations. And further, even when we are recruiting minority participants and reporting this in a sub-analysis, there are often not a sufficient amount of minority participants to make strong conclusions. The lack of minority populations is also a problem from the side of researchers, developers, and clinicians. The general IT field in the United States is 90% white and Asian, with other populations vastly underrepresented. And less than 20% of researchers attending recent major artificial intelligence conferences are women. And these types of biases can accumulate. For example, underrepresentation of women in imaging data used to train AI systems, underrepresentation of women in imaging data science and in clinical radiology positions could combine to result in significant negative effects. In some ongoing work, reviewing articles on trust in AI for healthcare has shown so far that 37 relevant articles, in 37 relevant articles, only 9 articles report race and or ethnicity, just less than 25%. And of those articles that did report race or ethnicity, many of them compared the perspectives of white individuals to all other non-white individuals grouped together. This falsely assumes that every non-white group holds the same perspective. This type of analysis could lead to a significant misinterpretation of results. If one group holds higher trust and another group holds lower trust, this could lead to the non-white group as a whole being seen as having trust equal to the white participants. Decisions in study design can change the interpretation of results in important ways. And while studies will never be perfect, it is also important to be able to understand what a study means, and in the case of health technology, also understand how a technology or AI system has been trained and what it can or cannot do. And that brings us to the final problem, the incomplete and porous education of and training of healthcare professionals and clinicians on the topic of technology and artificial intelligence, as well as in diversity and ethics, problem which has begun to attract some attention, but has not been sufficiently addressed. And just a quick story. So not too long ago, I viewed an online panel about the use of artificial intelligence in medicine. And I was pleasantly surprised that the topic of bias was appropriately addressed, which in hindsight, I should have recognized that would be the case, as one of the speakers was the author of a paper on bias in the use of AI systems to diagnose skin cancer. Again, displaying how historical injustices with camera systems and resulting images could feed forward to amplify a bias and create injustice in healthcare. However, something else stood out in the comment that the panelist made. He expressed not being concerned about the training of clinicians on the use of AI systems, pointing out a comparison between artificial intelligence and the use of electronic health records. I don't believe that this panelist was an informaticist, but he is a clinician. And that stood out to me for a couple of reasons. One is that recognizing bias tends to require a framework for thinking about bias, which needs to be learned. But second, EHR systems are poorly used, in part because they can be complex, but also in part because they are often not taught well to users. This isn't an indictment of EHR trainers, but more on the lack of time dedicated to it from medical school onward. And yet, this clinician who has focused on bias in the use of artificial intelligence did not recognize that deficiency in the use of EHRs. One of the points of that story is that there's already so much for clinicians to learn. Medicine is a large, complicated, and difficult field. There's always a lot of discussion on what is most important to know. Medical education has always needed to keep pace with technological advancements, but these advancements are coming more rapidly than ever before. And a number of professional medical associations such as AMA have put forth statements supporting the inclusion of AI in medical education. And teaching the use of AI to clinicians could help maximize the clinical benefit as well as avoid the harms. However, medical education is slow to adapt, and even when change does occur, it tends to be very small and incremental. Furthermore, medical education has always struggled to keep pace with the advancement of technology, and there are currently few physicians in teaching roles who have experience with the use of AI systems in healthcare. Meanwhile, the amount of potentially relevant medical information already far exceeds the capacity of the brain, yet medical education continues to focus on information retention. Now, I've briefly talked about 3 problems facing healthcare related to mistrust of minority populations and the use of technology and AI. Now I will give a quick overview of some work currently being done to address these problems. First is a study on exploring trust in AI for cancer care among racial and ethnic minorities. This study is the most direct study on the topic and will include focus groups and surveys to engage with the community on how much trust exists for AI systems intended for cancer care across the spectrum of care, and how different groups might have different concerns that may need to be addressed in different ways. I'm currently working on the IRB protocol for this study and working with a group of other great researchers, including Nicole Wilson, Jen McCormick, Teja Ganta and Victor Borza. And then second is a study on the development of an online training module for clinicians on algorithmic bias in healthcare. This work was used as my master's capstone while at OHSU and will be fully presented at the upcoming AMIA Symposium. But it involved literature review, qualitative assessment, programming the online module, and then surveys used to receive feedback on that. A link to the module will be available at the end of the presentation if anyone is interested in taking a look. Then third study, evaluating medical students and residents on the appropriate use of AI systems in patient care. This work will involve developing clinical simulation scenarios and randomizing students and residents to a scenario where the AI system is being used appropriately and a scenario where it is not being used appropriately and may provide incorrect output for the patient. And the intention of the study is to see how well the students and residents adapt to the use of the AI system. And what more can we do about all of these problems? So to start, we need to be aware of the problems and how people react to those problems, such as bias, and taking time to recognize our biases. When conducting research, we need to listen more to people from the community, especially those who may be disadvantaged by AI, and to recruit diversely. But to simply recruit diversely does little good if we don't use that diversity to support stratified analyses of the outcomes. There needs to be more training on diversity, ethics, and the use of technology. And we need frameworks to facilitate thinking about issues of technology and justice or equity in healthcare. These frameworks may not be solutions, but they will serve as a solid starting point to reach solutions. There's also a need to intentionally pay more attention to researchers from marginalized backgrounds who have associations with the potential harms of AI, and to recognize their work through citational justice. And then we need to also speak up. Policy often comes too late on its own, often as a reaction to a problem that has already taken hold. I was actually just in Washington, D.C. last week to learn about federal science, technology, and education medicine policy. And there is interest in Congress on the use of artificial intelligence and concern about bias. And while I'm not here to make a political statement, that concern was represented on both sides. And advocacy is really another part of the health professional responsibility. And this brings us to the conclusion. To summarize, trust is clearly an important issue in healthcare with real clinical effects for patients. And this already complicated issue will be further complicated by the use of emerging technology and AI in healthcare. Bias has been and will continue to be a large contributor to the mistrust that minority patients may have in healthcare. And yet, there also remains a lack of awareness of this bias. That lack of awareness is in part because we don't listen enough to minority perspectives, including minority patients, clinicians, and researchers. There isn't enough education and training on these issues, including the use of technology in healthcare. And while we are facing a critical point in the paradigm shift towards digital health, there is still plenty that we can do to help minority patients and to gain their trust from being aware of the problem to advocating for addressing those problems. And I'll leave you last with a quote from Langdon Winter, where I added a little bit to frame it on technology in healthcare. The important question about technology becomes, what kind of world are we making? This suggests that we pay attention not only to the making of physical or digital instruments and processes, but also to the production of psychological, social, and political conditions as a part of any significant technical change. Are we going to design and build circumstances that enlarge possibilities for growth in human freedom, sociability, intelligence, creativity, and self-government, or health equity and justice in healthcare, or will we go down a different path? With that, I thank you for your time. If interested, you can reach the algorithm bias module via the QR code here or the listed website address. And I'm open to any comments, feedback, or questions either now or through email.
So Ben, thanks so much for kind of highlighting this really important topic and making us think about it. I have one comment, and then I know that Ben Sanders has a comment on a question on chat as well. My comment is this: that bias in healthcare has existed long before the advent of technology or AI, and it has predominantly been fueled by clinicians. And of course, bias in technology has existed long before the application of AI to healthcare, and that has been fueled predominantly by programmers. And when I start thinking about this topic, what strikes me the most is that there is a societal root to this bias that transcends the environments that we operate in, right? I mean, the bias exists as a universal superset of the entire gamut of activities that we participate in, whether it's in healthcare or the gamut of experiences that we have, whether it's in healthcare or anywhere else. And so to me, the biggest question that I have is, can we actually truly eradicate bias in specific elements of healthcare IT, like AI, without addressing the elephant in the room, which is the eradication of bias in society?
Yeah.
How do you square that circle, Ben? What do you think about this?
Yeah, that's actually pretty similar to, we actually had a conference at the ethics department here a couple of weeks ago where I actually made a similar comment. And I realized that like people in healthcare are representative of the larger society from which we come from. There's really no getting around that. And so the question is then, how do we really get ourselves to recognize the way we think is imperfect, and to pursue improvements? And that really starts with awareness. If we don't believe that what we're doing is wrong, then we'll never do anything about it. So that's really the first step. And then it is true that if society doesn't change, then how it's reflected in healthcare is really not going to change either. But there's also the perspective that healthcare can step forward and be a leader in that change.
I think you're right, Ben. If no one else does, we have to do it, right? I mean, the work needs to be done. Ben Sanders says, "Thank you, Ben. Really well done presentation, important work. What can you say about current or future efforts to revise IRB ethical standards to address these issues of bias in research design or related to this in publications?"
Yeah, that is tough in terms of like that. There's also the underlying question of, particularly for artificial intelligence, of where research begins and ends, and where clinical care begins and ends. As the IRB obviously doesn't have oversight over like, the use of these systems for clinical care once the research is over. And yet we clearly need some sort of oversight over that as AI systems can change in their effect over time. So when we're looking at the IRB in particular, is there enough expertise in the makeup of the IRB groups? In general, IRB is not there to make specific recommendations. They're really there to identify large principles and to enforce those larger principles. And it doesn't really get into the smaller details. So maybe we might need a more fundamental change or something new to address artificial intelligence in particular.
I think that's a great point. I appreciate that perspective. I was just thinking about like protected populations, right? So there are a number of ways which IRB currently carves out and sort of identifies groups that are particularly vulnerable to risk in scientific studies. And I'm just thinking maybe we should be extending that kind of very sort of protection of specific populations by incorporating the maybe concepts of anti-bias, whether or not it's AI.
Yeah. I think from another perspective, there's also the question of how much is too much from the IRB side. So, and your question is actually quite timely in that for the algorithmic module study that I mentioned, so I did 2 phases of the study. One while I was at OHSU, and one attempting to do here in terms of getting survey feedback for the module. OHSU IRB approved with no issues medical student involvement in that. Vanderbilt has not, and part of that is that students are considered protected populations. But how can we learn about protected populations if we build a wall around them and a wall around the issues that they are involved with? So like if we're looking at bias, I really don't have a good answer for this, but would we say that like certain types of studies need to include some way to make sure that they're not including too much bias, or to measure the amount of bias that they're including in that study? And that I don't know.
And Ellen says there are other strategies than IRBs to address this. And also she mentioned that, IRBs are not competent or empowered to do this. And I know one thought I have is you can empower IRBs to do this. But I would be really curious. I don't want to put Ellen on the spot, but I'd be really curious as to both what Ben and Ellen thinks are other strategies other than IRBs.
Ben, do you want to respond first?
Sure, I can do that. So I think some of it will ultimately depend on how the FDA responds to the use of AI systems. As of right now, they only approve static systems that don't change over time. If they want to start approving systems that change over time, then the oversight from the FDA would likely need to start earlier, particularly from the research phase. Then there's also the opportunity for other third-party ethics specialists to provide input.
Well, and I'll be a little bit more radical than that, which is that I think the real thing that we need to be focusing on is how these tools affect people, and to, to understand what some of their concerns are, to get feedback as we go along. I'm not advocating necessarily, community-based participatory research, but I think that we need, this is one of the reasons why it's very important to have a diverse array of investigators in the room and a diverse array of participants. But I think IRBs have a very rigid approach to how they think about risk, as we're seeing here at Vanderbilt, and I'm not sure that that really helps. I think if our focus is trying to develop tools that address that address the concerns of the people who they're going to be used for and with, I think that's the better way to do it. I just don't think our IRBs have actually been told they can't look at downstream social effects, and they really can't evaluate the strength of scientific protocols. So we need to do something different. That's what I would say.
Ellen, it's interesting you say this, because the very reason IRBs were created was because as a society, as a species, we've, I think, proven that we're incapable of conducting unsupervised research without harming people. I mean, to me, what you're saying suggests that the IRBs have become too rigid an institution. Could elasticizing the role of what an IRB, or rethinking what the role of an IRB is for the 21st century, be one way to address this? I mean, the IRBs were a result of a 20th century commitment to cleaning up research, right? So should we rethink that idea of what cleaning up research means?
Oh, without a doubt. And, and one of the things about IRBs is that they act in service of the institution, not in the service of research participants. I mean, they've been utterly captured. And so I think there is a lot. I just talked with the head of the National Academy of Science over the weekend, and I know that there is a general feeling that IRBs aren't doing their job, and they're not. They are both getting in the way, and they're getting in the way of research at the same time, not ensuring that all the relevant interests are taken in stake. So I think we will see a move in the next 10, 20 years to re-examining what the role of IRBs is, because I think they don't work well. That's kind of a downer, but I think, on the other hand, I think this kind of work that is focused on what this research means for people and what it's going to take to deliver tools that clinicians could use in ways that patients accept, is going to require a different way of thinking about it than sort of the strategies we've done in the past.
Absolutely. And Steve said Stanford has experimented with a variation on the IRB model that's designed to think beyond the study and look at downstream effects. And that's an interesting link. And Steve also said that, to think about bias is too generic, framing it more about risk and harms makes it easier to think about what kind of bias is relevant and what the best way to think about that in the context of a specific study. And that's a really good point. One thing I do want to focus on, Ben, is the two themes I got out of your presentation. One, of course, is that of bias. The second is that of trust. And to me, mistrust in certain sections of our society is based on history. And And you could actually argue that mistrust in some populations is entirely justified. And so once, a patient engages with, a clinician and learns over time to develop trust, then certainly, trust in AI becomes the next level kind of reach goal. But we are struggling in a society where where folks are mistrustful even of engagement. And so how do we then think about, trust of AI and AI related technological features of healthcare delivery when even fundamental elements of trust, such as, engaging with the healthcare system, are in jeopardy?
Yeah, that's a good question. I think like when we've historically attributed trust and mistrust to history itself, like we've tended to lean on specific events, like the Tuskegee study, and saying like, oh, these events are why there's mistrust, and that's partially true, but it's much more than that. It's an ongoing, continuing experience. I think there's a lot in terms of like being able to communicate well with each other and understanding different cultures. I understand that. So there's the ongoing NIH work on AI through the Aim Ahead program, and they have had difficulty with working with Native American population due to really understanding different cultures. And as they learn from that, they can apply that more broadly, but that also leads to impasses where, like, once you get to a block, it can be difficult to overcome that. And a lot of those blocks are very early in life as well as in the care process. People learn early on that the healthcare system is not for them, or and the way that they interact with the healthcare system tends to reinforce that, particularly the inability to get healthcare. And it may not be until we have some sort of universal healthcare system, at least in the United States, that we can really do that. It's like if people are to pay massive amounts of money or they can't get the care that they need, then they're never going to trust the system.
Any other questions for Ben or comments? And if not, I want to thank Ben so much for this presentation, and I think making us think about this really interesting and important topic. And Ben, welcome back, and come back anytime and talk to us some more. We'll always be happy to learn from you.
Okay. No, thank you.
Thanks, guys.